Good afternoon, everyone, and thank you so much, Dr. Chakra, for inviting me again to this exciting annual meeting. I have no disclosures. So I wanted to start saying that preparing this talk was particularly challenging. And one of the reasons is that if you search in PubMed for multiple sclerosis treatment over the last year, so from 2020 to 2021, you will find more than 3,000 results. So obviously, not all those results regard new medications, but many of them do. Even more interestingly, if you go to clinicaltrials.gov, which is a website that basically tells you about all the ongoing or about to start clinical trials on about any diseases, and you try to search for MS and drugs, you will find more than 200 studies which are going on, which are recruiting or about to recruit patients with MS. So there are many medications on the pipeline. And in this talk, I just tried to put together what I thought it might be more interesting and useful for our clinical practice. So we are just going to start talking about the latest approved DMTs very briefly. Then we are going to move to the novel strategies, which are mainly directed into neuroprotection, remyelination, neuro repair, and regeneration. I always like to show this slide because it's impressive to see how the landscape in MS medications have changed during the last years. So from 1993, in which the first drug for MS was approved, interferon beta-1b, then to 2018, obviously the slide is not completely updated, we had so many different DMTs that were approved almost every. So this is a list of the currently approved DMTs for MS. As you know, they are all basically immunosuppressants or immunomodulators. So they act on the inflammatory component of the disease, but they don't seem to be very effective in preventing the secondary progressive phase. On the pipeline, we have the BTK inhibitors that target B cells as well as myeloid cells. But we are not going to go into details. We're not going to discuss BTK inhibitors today because I wanted to focus on different topics. The latest approved drugs are ocrelizumab, its cousin ofatumumab, siponimod, the very new ponesimod, which has not been yet approved in the UAE, relatively new cladribine. And I also wanted to briefly mention about the autologous hematopoietic stem cell transplantation, not because it's a new treatment, because we've been using it for many years. However, more recently, it has been proposed as a possible standard of care. So it means we are moving towards being able to offer this treatment for patients with relapsing remitting MS as a second line, instead of keeping it as the very last option, as this recent paper published in 2020 by an Italian group wanted to show. So let's move now to emerging strategies, which is the main topic of our talk. We all know that nowadays, the disability progression in people with MS progresses through two main different mechanisms. So we have the relapse-related damage, which is mainly mediated by inflammation, and we have a chronic progressive CNS damage, which is basically related to neurodegeneration. If you remember, years ago, we used to think that MS was a purely inflammatory condition. So nowadays, with the development of new MRI techniques and several pathological studies, it has been shown that inflammation and degeneration are actually both present in people with MS, and they seem to be going on from the onset of the disease. That's why the emerging strategies to treat MS focus on these three topics, which partially overlap, which are neuroprotection, remyelination, neuro repair, and regeneration. So we're going to start talking about neuroprotective strategies. The goal of neuroprotection is to preserve the CNS architecture and function. This strategy is critical because as we all know, the CNS has a very poor regenerative capacity. In MS, there are many different biological mechanisms that are associated with CNS damage, and they have been proposed as possible targets for neuroprotection. So here is a picture that summarizes those targets. Obviously, we are not biologists, so we are not going to go into details regarding that. And I wanted to show you how many drugs are under investigation to be possible neuroprotective drugs for MS. Again, we are not going to go into details on all those medications. I just wanted to show you the numbers and just to focus on some of them. So we find here biotin. Biotin has been studied in people with MS, unfortunately without significant results in preventing disability. And moreover, it interferes, as you know, with the blood results. So its use at the moment has been abandoned. Simvastatin is a very promising drug that we've been using for MS for many years, but we're going to discuss it a little bit more in details later on. Riluzole didn't show any efficacy in MS. Then we find here in this list some drugs that we use for epilepsy. We're all very familiar with phenytoin, carbamazepine, oxcarbazepine, and lamotrigine. However, so far, not many studies have been done, so we're not going to go into details. We find here some drugs that we are currently using for MS: interferons, GA, S1P inhibitors, fumarates. Those drugs, apart from being immunomodulators or immunosuppressants, seems to have some effect in neuroprotection as well. There is Ibodylust, which we're going to discuss in a while. And again, we find fumarate, biotin, and style. So let's start talking about Ibodylust, which is a small molecule which was used for a few years for the treatment of asthma as well as post-stroke vertigo. Ibodylust, as I said, is a small molecule and it can cross the blood-brain barrier. It is taken orally twice daily, and as possible side effects that have been reported, there are GI side effects such as nausea or diarrhea, as well as depression. A phase 2 clinical trial has been published on relapsing remitting MS, in which patients who took Ibodylust didn't have any significant reduction in development of new lesions. So Ibodylust didn't show any significant effect in the inflammatory component of the disease. However, it was seen that Ibodylust was able to significantly lower the progression of brain atrophy and also decrease the proportion of gadolinium-enhancing lesions that converted into black holes. Because of these results, a second trial was done to test Ibodylust on patients with secondary progressive MS. So this trial, which is called Sprint MS, showed a slower progression of brain atrophy in people with primary and secondary progressive MS over a period of 2 years compared to placebo. Here is the trial, if you want to go through it more in details. I wanted to show you this result. In this graph, you can see in the red dashed line, patients taking Ibodylust, while the blue dashed line are the patients who were taking placebo. So patients on Ibodylust developed 48% less brain atrophy compared to patients on placebo, which is actually very significant. So I just put here another few drugs in which brain atrophy has been tested. Ocrelizumab was able to decrease brain atrophy by approximately 70%. Siponimod, we are in the range of 15%. And simvastatin, which we're going to discuss later, was 43% reduction in the development of brain atrophy. So again, Ibodylust showed very interesting results in the field of brain atrophy. Unfortunately, however, when they measure the clinical outcomes, Ibodylust didn't show any significant effect compared to placebo in decreasing the rate of disability progression. So you can see, in fact, that the two lines, the red line for Ibodylust and the blue solid line for placebo, they almost overlap. Another study went to see the effect on neurofilament light chain in people taking Ibodylust compared to people taking placebo. So this study, which is about to be published on the Multiple Sclerosis Journal, unfortunately did not show any effect in reducing the neurofilaments in patients receiving Ibodylust compared to the group receiving placebo. So these results might be explained by two phenomena. So potentially Ibodylust maybe doesn't have any effect on neurofilaments because it doesn't have any effect on disease progression, or it might be that, as it has been already shown in the past, neurofilaments are not a good marker for degeneration, while they are more linked to inflammation. So obviously further studies are needed to see whether Ibodylust can be integrated in our clinical practice in the next years. So let's move to statins. We all know statins. We've been using statins for many, many years to treat hypercholesterolemia. Statins seem to have also a significant immunomodulatory and neuroprotective properties, and they also have a very good safety profile and low costs. There have been studies in patients with relapsing remitting MS, and they didn't find any clear beneficial effect of statins in reducing clinical and MRI disease activity. So again, it seems that statins doesn't have any effect on the inflammatory part of the disease. However, a study which was called MS-STAT, which was conducted on patients with secondary progressive MS, showed a significant reduction in the annualized brain atrophy rate in people taking statins compared to patients taking placebo. So it's a 43% reduction, very significant. So here is the paper if you want to go through it. And here is the main results. So you can see in the dark blue line, the group receiving placebo, and in the light blue dots are the people receiving simvastatin, which was given at high doses of 80 milligrams daily. Those are the results over the first year, over the second year, and those are the cumulative results on the entire study period, which was, as I said, 2 years. So as you can see, patients taking placebo compared to patients taking simvastatin developed significantly more brain atrophy. So we are going to move now to remyelination, possible remyelination strategies. As you know, the myelination of both white and gray matter is a key pathological feature of patients with multiple sclerosis. Spontaneous remyelination can happen, but the amount is actually variable and seems to be very low and decreases with age. In fact, despite the presence of oligodendrocyte precursors in MS lesions, which has been demonstrated by several studies, remyelination is generally unsuccessful, or at least partial, after the myelination occurs. Moreover, the myelination in MS seems to occur not only inside the lesions, but only outside the lesions, in the so-called normal appearing white matter, as some studies, MRI and pathological studies have shown, especially in the later stages of the disease. Chronic demyelination not only lower the progression of the signal along axons, but also is believed to contribute to axonal loss, which actually results in progressive and usually irreversible disability in the secondary progressive phase of the disease. Remyelination, on the other hand, can restore axonal conduction and can therefore contribute to clinical recovery potentially. That's why remyelination has been always considered a very important target for patients with multiple sclerosis and in the development of new DMTs. And as potentially remyelination can stop disability accumulation and can also potentially reverse some of the already accumulated disability. This is a picture that shows all the possible targets for remyelination, but again, we are not going to go into details about this figure. And here is a list of the remyelination therapies that are on the pipeline. Again, we are not going to go into all of them in details, but I just wanted to mention Opicinumab, which was considered a promising drug, but unfortunately a study that was going on last year was stopped before the end of the study because the drug didn't show any effect in preventing disease progression. We find here clemastine, which we're going to discuss more in details. Some drug that we know already that we are using for other indications, such as quetiapine or domperidone, so far didn't show any effects. Particularly, there was a small study on domperidone that didn't show any effect in preventing disease progression. We find in this list again biotin, simvastatin that we already. So we are going to start talking about clemastine, which is an old antihistamine, which can cross the blood-brain barrier and can induce oligodendrocyte differentiation and myelination due to its off-target antimuscarinic effect. There was a trial called Rebuild that suggested that the use of clemastine in people with MS could potentially result in a small improvement in the VEP latency measured on the P100. The visual system has been proposed as a good method to study remyelination because we can measure quite well the latency. So it has been used in trials for new drugs that target remyelination. Here is the study. So here is the main result of the study in which we can see that how the study was built. So there was a group 1 who were the patients taking 3 months of clemastine first, followed by 2 months of placebo. Then there was group B or group 2 in which patients were receiving 3 months of placebo, followed by 2 months of clemastine. So the group A, which is the light blue line, who received the clemastine first, showed a significant improvement in the VEP latency over the first 3 months in which they received clemastine. And this effect was maintained over the following 2 months in which they were receiving the placebo. The orange line represents the group 2, which was taking placebo first. And as you can see, the VEP latency was pretty much stable until they received clemastine in the following 2 months. And then the VEP latency significantly improved over the time patients were receiving clemastine. So obviously, we are still far to say that clemastine will work, but more studies are needed, but it seems to be a promising drug. So we're now going to move to neuro repair and regeneration, which is the last topic of our talk. We all know that prevention is the best therapeutic strategy for any disease, not only for MS. And unfortunately, we are not yet able to completely prevent and avoid CNS damage. That's why CNS regeneration for people with MS is a very promising strategies, especially to reverse potentially the already accumulated disability. So in the setting of neuro repair and regeneration, a lot of attention has been put on mesenchymal stem cell transplantation over the last few years. Mesenchymal stem cells are non-hematopoietic stromal cells that reside mainly in the bone marrow. They seem to have significant immunomodulatory and neurotrophic effects. Here is the only paper that I found that went to study autologous mesenchymal stem cell transplantation in active progressive MS against placebo. It's a small study that showed some beneficial effect, as we can see in these pictures. So in picture number 1, we can see the effect of the EDSS progression in patients with MS. So the white column represents patients who were stable or improved. The dark color represents patients who deteriorated. And we can see in the first part of figure A, the effect of mesenchymal stem cell transplantation in people receiving the drug, the stem cells in the intrathecal way. In the second part of the figure, we see patients who were receiving stem cells through IV, and then we have the placebo group. So as you can see, patients who were receiving the intrathecal mesenchymal stem cells showed a significant stability or improvement compared to people on placebo, while patients receiving the IV were improving, but not as well as patients receiving mesenchymal stem cells through intrathecal way. We can see the same thing in a different way in the figure B, in which we see in the dark solid line patients on placebo, in which the change in the EDSS was much faster and significant compared to patients receiving mesenchymal stem cells, in the dashed line here below, in which EDSS was overall stable. Here is the results on the number of relapses and gadolinium-enhancing lesions. So in here, we can see the relapses in patients receiving intrathecal mesenchymal stem cells, intravenous mesenchymal stem cells, and placebo. So it is visually clear that patients on intrathecal mesenchymal stem cells develop less relapses compared to the other two groups, and the same effect reflects obviously in gadolinium-enhancing lesions. Now, although patients are asking very often about this treatment, and although we know that they are going abroad to get this treatment, we are still far to have it approved in our clinical practice. So one of the reasons is that we need bigger studies. So this study was actually conducted on a very small sample of patients. And the other reason is that we have some concerns regarding possible side effects or complications, particularly related to possible development of infections, ectopic growth tissues, tumors, and also it is not yet clear what would be the best protocol to store and administer mesenchymal stem cells. So we're still far to use it in clinical practice. The last drug that I quickly wanted to discuss with you is Alexanumab. So Alexanumab is a monoclonal antibody, fully humanized, which is directed against a molecule which is called repulsive guidance molecule A. So it seems that this molecule is upregulated in people with MS, and this molecule is able to inhibit axonal growth and myelination, as well as oligodendroglial regeneration and functional recovery. So Alexanumab might potentially promote axonal regeneration, neuroprotection, remyelination, and immunomodulation, but the trial is still going on. So we will see the results in the next year. So coming to the conclusion of our talk, we have seen as how much the landscape on MS treatment has changed over the last years, from the approval of the first DMT in early 19s up to now, in which we have more than 15 drugs approved. However, we are still far to have the cure of MS, but there has been much progress in developing new MS drugs to treat it, so we can give our patients a big hope. The treatment targets are changing over the years, along with our understanding of the pathophysiology of the disease. So as we said, current DMTs are immunosuppressants or immunomodulators, so they target mostly on the inflammatory component of the disease, while new therapies will target neurodegeneration, remyelination, neuronal repair and regeneration. Many drugs, as we saw, are under development, but more data are needed before we will be able to use them in our clinical practice, hopefully in the next 5 to 10 years. So I'm finished with my presentation, and I wanted to thank all the MS team at Cleveland Clinic Abu Dhabi, and thank you for your attention.